patient questions I have, and these actually are real patients I've seen in the last week. So I have an 82-year-old patient with end-stage renal disease who's currently hospitalized with complications of peripheral vascular disease, severe inoperable aortic stenosis. He's had multiple hospitalizations in the last 6 months since moving to the Denver area. Fluid removal on dialysis has been challenged and limited by hypotension, and he's now being transferred to a skilled nursing facility and will soon return to the outpatient dialysis unit. So one of the tasks I have is to address his code status. So how would you approach this patient when he comes back?
Sure. And open-ended questions are best. And I might even start with, how is it going with you on dialysis, to see what type of insight he has. Obviously, as nephrologists or nephrology clinicians, tight aortic stenosis we know is very challenging, and really there's no good answer other than switching them to peritoneal dialysis, if they're a good candidate, right? I don't know if that's your experience. That's certainly my experience, especially really, really critical aortic stenosis. So I would first see if he has some awareness that things aren't going so well, he's dropping his blood pressure. The second thing is, I would not go right for a code status discussion. I would really sort of want to take one step back and see what his overall goals for care are. And ask, for example, if he got very sick, would he want to be put on a breathing machine? And to see, most people don't like, especially older patients, really tell me they wouldn't want to be on a breathing machine in the ICU. And you could say, if your condition were to get worse, would you want to be on a breathing machine? Now, what you've told me is that he has two life-limiting problems in addition to his kidney disease. He has critical aortic stenosis that's inoperable, probably has 6 months or less to live from his aortic valve disease. And then he has peripheral arterial disease, which confers a 2 to 3 times greater risk of mortality in the next year for dialysis patients. So I think I need to engage him. How is it going? Are there certain treatments he would want to avoid if he were to get sicker? See what type of insight he has. See if you can get him to open up, and then take whatever he says as a cue to then follow up. And if he says, well, things haven't been going that well, then I would follow up and say, well, what do you mean not going that well? What in particular do you have in mind? I think that would be my goal. And it sounds like you've had this conversation with him already, correct?
Correct.
How did it go? How did it go?
He was in the midst of the hospitalization, very focused. I'm having a peripheral intervention on Thursday, another one on Friday, and then not seeing the forest for the trees. So obviously These are not time limited, one point in time conversations, but ongoing conversations that as you build a relationship with them. So
could I just make a point about that? The point that you made is exactly what everybody else has reported in studies, that hospitalization is not the best time to have an advanced care planning discussion or even a shared decision. Well, shared decision making you have to do, but advanced care planning, people tend to want to put them off till they feel things are more stable and maybe more under their control. And if he's in the hospital, he probably doesn't feel things are under his control. So the only thing you can do in the hospital, though, because you might need to do it, especially if he's going to have procedures, is just determine if things were to get bad and the only way to keep him alive was to put him on a breathing machine in the ICU, would he want that? And I would go there before I would go to a code status discussion.
Okay. But if by chance you do, I'm going to press you here, if you do end up addressing code status, what do patients' expectations of CPR align with the real life experience?
And I think the answer is no. They way overestimate the effectiveness of CPR. TV does a great disservice to patients by educating them that everybody survives CPR. And so again, you need to sort of find out, is his understanding of CPR what he sees on TV? And then really, sometimes we do a tell, don't ask. And honestly, if a patient with bad aortic valve disease and severe peripheral arterial disease were to have a cardiac arrest, I would really tell him it's very unlikely that would work, and really I would not recommend it. I would be fairly strong in my recommendation that he not have it.
Okay. Well, it's interesting because I think often as physicians we try and be agnostic with our approach to patients, saying here's the menu of things that we can do for you. What would you choose? So you're advocating actually taking a position and saying, in my medical judgment, here's what I would recommend.
Right. And it's interesting, the medical ethics literature suggests that physicians use their experience and training to make recommendations. There are 7 elements of informed consent described in Beecham and Childress's Principles of Biomedical Ethics, which is like the #1 sold medical ethics book in the country. And they say one of the elements is that the physician is to make a recommendation. So with regard to CPR, I would say, after sort of figuring out what's his understanding of it and how likely does he think it would be a benefit to him, and he might say, well, I don't know, then I would say based on your heart disease and your peripheral arterial disease and your kidney disease, it's very unlikely to help you, and I would recommend that we not do it.
Okay, great. Let's take it forward in this conversation or later conversation. In follow-up to your question, he does admit that he's frustrated with his multiple admissions, his deteriorating quality of life. He's no longer living independently. Now he's in a nursing facility. So how do you introduce the possible or the concept of possibly withdrawing care?
Okay, well, I might say as your nephrologist, I'm having more and more difficulty keeping your blood pressure up on dialysis, and we're having trouble. I'm just assuming maybe removing fluid, and so I'm concerned that you're going to accumulate more and more fluid. What was your understanding of what the cardiologist told you about your heart valve? How bad is it, and what could he do for it? So often I take patients back to the discussion because although you and I know the significance when the cardiologist says, well, you can't have any surgery done, we'll have to manage you medically, patients often think, oh, well, there's something that you can do, you'll manage me medically. What they don't understand is that surgery is the only definitive thing, or now a TAVR, but maybe he wasn't a candidate for a transaortic valve, replacement. So if he's not a candidate for a TAVR, not a candidate for aortic valve replacement, then really you have to bring him back to what is the significance of what the cardiologist told him. Now, in my experience, maybe in your experience too, frequently cardiologists don't go into what are the implications of the fact that you've got inoperable aortic valve disease. Is that true? Did you have enough of a discussion?
You're okay. They say you're okay, meaning that you're not likely to drop dead that day. So
that's right.
Okay.
So honestly, it creates a challenge for all the rest of us because the cardiologist honestly didn't do his or her job.